I'm going to try to talk about not just what we've learned, but what the challenges have been, and maybe even a little bit about what the future looks like in terms of heart disease prevention. Because it's clearly a big topic, and if you look at the volumes of literature, and particularly the volumes of opinion, you're going to be confused. You won't know what to do or where to go. So what we've tried to do is stay focused on things that are out there that seem to work, and that's some of the things I'm going to share with you. What have we learned over the last 25 years? One thing that we know for sure is that if we knew we were going to live this long, we would have taken better care of ourselves. And we can all share in that. But probably more apropos is the idea is to die young as late as possible. And when I say that, successful aging is time you can spend free of illness and disability. And that's really one of our goals, is for people to live as full and rich a life as they can. There's a Tibetan proverb that says to live a full life, you should eat a half, you should walk double, you should laugh triple, and you should love without measure. And that just works if you think about it. So you all got a handout which we put together, which were 10 things that we thought would be ideas that someone that you could start 1, 2, 3, 10, whatever, that would be helpful. That's to go home. I'm not going to go over those, some of which we'll talk about. But what I do want to talk about is to make sure we're all on the same page in terms of the topic. And the topic is atherosclerosis. It's got multiple names. Plaque is probably used the most. But we're talking about arterial disease, which can happen anywhere. We're focused on the heart, but it could be your carotids, it could be your abdominal aorta or your femoral arteries, it could be anywhere in the body. And the process is, when we're born, we don't have any plaque. We have an artery, which has a single layer of cells called endothelium, which is the inside lining. Here's where the blood flows. Here's the wall of the artery. So when you feel your pulse, you're feeling that muscular artery pumping out at you each time your heart beats. When we're teenagers, we start to develop fatty streaks. Fatty streaks are deposits of cholesterol in the walls of the arteries. In most cases, they don't grow. They even go away. We don't know why it happens, but it's just a process. But in some people, and we think this is because of risk factors that are not attended to, fatty streaks become atheromas, which are the original plaque. And we know this is there because autopsy studies of young people who have been killed in war or killed in trauma, 50% of them show up with some atheroma. They're not obstructing it, the artery, but they're there. And after several more decades, you can advance to the point where you have complex fibrous plaque, and now you can see how the channel for blood is narrower, narrower, narrower. This is when you start to develop symptoms, which we'd call angina, and it comes in different shapes and sizes. Eventually, if the plaque ruptures and comes in contact with the blood, a clot will form, and the clot will block the artery, and that's what a heart attack is. But what we're talking about in the heart series and today is how do you prevent and reverse this process? So let's start with what causes plaque. The first maybe 10 slides are the god-awful worst because there's a little bit of research and some terms that I can't pronounce. But once we get through those, it will get better, I promise. So what causes plaque? It's called chronic inflammation and oxidation. These are both processes that are going on in our body normally, but for whatever reason, they get a little bit out of their normal sync, and we end up with plaque forming. So what is chronic inflammation? Chronic inflammation, it's the normal immune system acting outside its normal role, resulting in damage to joints, blood vessels, skin, brain, and probably other areas. The normal immune system is made up of white blood cells and proteins and probably some other structural content. but it's surveillance. It's on duty 24/7. It's there to identify bacteria, viruses, funguses, allergens, anything that can come into our body and hurt us. And the immune system neutralizes, destroys it. If a cancer cell forms within us, the immune system can identify it and take it out. Constantly working. So it's a normal process. But the formation of plaque by this immune system, that's not a normal process. So here's a cartoon. We could take a lot of time on this. I'm not going to do that. I want you to stay awake. So what you're looking at, though, is the immune system in the process of making plaque. Here's the arterial lumen. This is where the blood flows. This is the arterial intima. It's a very narrow border, internal border of an artery. And then the outer part of it has smooth muscle. The action happens in the intima. So the process of plaque formation, which involves normal cells of the immune system. Here's the endothelium. This is the single layer of endothelium, which separates the arterial lumen from the intima. Different proteins get deposited on the endothelium and attract white blood cells, attract LDL, low-density lipoprotein. And what happens is the white blood cells get through the endothelium into the wall of the artery, and in this case, a monocyte differentiates into a macrophage, which is a phagocytic cell, a cell that eats things. LDL comes into the artery, becomes oxidized. The macrophage eats the LDL, grows into a foam cell, a large foam cell. All of these cells can secrete proteins called cytokines or growth factors, which stimulate other things to happen, such as smooth muscle cells to proliferate. Eventually, the foam cell bursts, deposits its content of enzymes and cholesterol in the wall of the artery with the smooth muscle cells, and now you have plaque. That's what forms plaque. At the same time this is all happening, once plaque starts to form, there's no way for any of these producers of plaque to get out of the cell. So you can find normal immune system products in plaque at any given time. But this is how it forms, and this is what we're trying to reverse. So why is this happening? What are the stimuli for chronic inflammation? Why does chronic inflammation happen in a way that causes plaque? And the list is big, and the list is risk factors for vascular disease. What a surprise. Obesity, diet, diabetes, stress, smoking, allergies, persistent injury or infection seen in tuberculosis or other chronic infections, or environmental toxins can all stimulate the immune system to behave in an abnormal fashion. It's like, excuse me, it's like just having smoldering embers existing inside us, waiting to catch fire. So that's inflammation, and then oxidative stress is the other feature that causes plaque. Again, a normal function. Oxidative stress is part of our immune surveillance system. Here's how it works. It's an imbalance between what are called free radicals, which I will define in just a minute, and our antioxidant capacity. Now, we're all familiar with antioxidant medicines, which we would like to take. Excuse me. But I would tell you that you're going to get much more bang for your buck if your antioxidants come from your diet and not from a bottle of pills. Oxidative stress is caused by radiation, smoking, hypoxia, low oxygen, pollutants, normal immune function. In other words, this inflammatory immune system can set off oxidative stress, normal food metabolism, emotional stress, physical exertion. In other words, living creates oxidative stress. And the issue is, what's the balance within our body? We all have some inflammation. We all have some oxidative stress. But when it gets out of control, when it gets to be more than the body can handle, that's when bad things happen. So these are normal systems acting in abnormal fashions. And the damage it does, oxidative stress can damage or destroy cells and DNA, leading to inflammation and cancer. So how does that work? You have a normal oxygen atom, which is part of when we metabolize anything to create energy, metabolize food, metabolize lipids or glucose or whatever. A normal oxygen atom can lose an electron and become what's called a free radical. Free radicals, their job in life, in their short life, is to find a new electron. So that oxygen atom without an electron will go seeking another electron. And it seeks it from lipids or proteins or other structures in cells. So it goes to a cell membrane and says, oh, okay, here's an electron, I'll take it. But when it takes it, it creates a new free radical. And the new free radical will go somewhere else to find an electron, which we'd call a chain reaction. And that chain reaction can actually cause a cell membrane to erode. And if the free radical gets into the interior of the cell, it can also affect the DNA. So the solution is for antioxidants, which are in our body naturally, some through our diet, vitamin C, beta-carotene, vitamin E, coenzyme Q10, and others that we manufacture, can donate an electron. Then you neutralize the free radical and you don't have the free radical damage. Now this happens naturally, just like inflammation happens naturally. But what we're talking about is things that have gotten out of hand. That's what causes plaque. So now we can talk about what we can do about it. So this is very stream of consciousness. You'll probably figure that one out. It's such a big topic. I'm going to jump from thing to thing. So now we're on healthcare. And healthcare in our country is otherwise known as disease care or sick care, because if you look at the resources we spend, we're probably spending 90% of our healthcare dollars on disease care. And we're probably spending 5 to 10% on prevention. Ed and I decided 25, 30 years ago that we wanted to live here and not here, which is where I lived for many years. So prevention or health promotion comes in three forms. One is primordial, which is a relatively new term. I don't hear it talked about a lot, but that's the prevention of risk factor development. So if you can get, and this is something that we need to think about as a country and as a world, if we can get to people young enough, we can prevent the development of risk factors in the first place. That would be primordial prevention. Primary prevention is trying to prevent an event once someone is hypertensive or hypercholesterolemic or smoking or whatever. How do you prevent them from having an event? Secondary is trying to prevent the second event after, or third event, or fourth event after someone's had an event. These are all forms of prevention, and these are all appropriate for prevention. When you think about healthcare reform, I'm going to digress a little bit now. Probably 75% of our healthcare dollars, we're spending like $3 trillion in healthcare, $10,000, $12,000 per person. And 75% of those dollars goes to chronic disease. If we were able to identify programs that could address chronic diseases and start to reverse and stabilize, we would have healthcare solved. But you don't hear that conversation. You hear it from me, but we're not hearing that conversation in Washington. That would be healthcare reform in a blink. Thank you. Time for a drink. Thank you. Okay, so I wanted to say a word about the Heart Series. Some of you know it well, some of you may not. But the lock is a metaphor for what we believe the Heart Series is about. And that's that if we want to really reverse, prevent, and stabilize plaque and heart disease, we need to address nutrition, and we need to address stress, and we need to address exercise, and we need to address community involvement, which would be the opposite of isolation, which is the least healthiest place we want people to be. And the reason we use a lock is because each of these tumblers has to be turned just right for the lock to open. I couldn't stand here and tell you which is more important. Our belief is that they're all important. And when you put them all together, that's when you start to get traction and you start to see things happen. Our mission statement is to reduce suffering, reduce hospitalizations, improve quality of life for individuals at risk or who already have heart disease. And our philosophy is give a man a fish, feed him for a day, teach a man to fish, feed him for a lifetime. We'd be just the opposite of take this pill. We want people hands-on to learn how to protect themselves. Now, this is the first time anybody's ever seen this. This is a slide of some results that we've done on research from 2012 to 2016. Gene Young is somewhere in the room. There's Gene. Gene is a statistician who helped us put the data together and create the slide with the help of her Tai Chi class. Gene told me that the class said, you need to use a bar graph and you need to have a color. So she did. So what I want to share with you is some results that we have from some research that we've done between 2012 and 2016. We had about 105 people who we were able to collect data on from before the heart series and then 6 to 12 months after the heart series. And then we compared those two. And this, I know you can't read the labels, but I'll go through those with you. This is the line of 0. So anything to the right means it went up, it got higher, more positive. Anything to the left means it got lower, more negative. So if we look at the parameters that we pay attention to, you start with weight, it went down. Body mass index went down. Systolic blood pressure went down. Diastolic blood pressure went down. Cholesterol went down. Triglycerides went down. HDL went up, which is what we want. LDL went down, fasting blood sugar went down, and the ratio of LDL to HDL, which is a very prognostic ratio for events happening, went way down. So this was exciting, and we're in the process of trying to write it up and form a paper from it. And I'm not sure where it will all go, but it tells us, it affirms that what we're doing is making sense in risk factor. And probably one of the most exciting pieces is that of these 105 people that we followed for almost a year, there was only one event. One person had a stent, successful stent. Otherwise, no hospitalizations, no heart attacks, no heart failures. Very exciting for us, right? Okay, so while we're talking about statistics, I want to show you 3 different studies, and I want to make a point on each one. The first one is going to be about statins, and that's the Cholesterol Treatment Trialist Collaboration. This was a big trial in which, I shouldn't say it was a big trial, it was a meta-analysis in which the people who wrote the paper looked at 21 different statin trials. These were randomized controlled trials where people either got a statin in different doses, it could be any statin, different doses, or a control group which didn't get a statin. And then they looked to see who had a heart attack, who had a stroke, who got an angioplasty or a stent or a bypass, and who died. And as you know, I mean, and I do this every day, and your doctors will do this every day, we believe that statins are a very effective drug for heart disease. And that's partially true. And I'll tell you why I say that. So in the group that got statins, 64,000 people, there were 7,136 events. Can't tell you which one, but one of these events. That's 11%. In the control group, about the same size, there were 8,934, 13.8%. So statins win. And if you do the math and create something called relative risk reduction, you'd say, okay, your chance of having an event is reduced by 22%. And that's what the media would see, and that's what you would read, and everybody would go, wow, we should all be taking them. But there's other ways to look at the data, and that's, I didn't mention this when we looked at the last slide, that's what's called residual risk. Residual risk is what's the risk that's left after we treat someone for something. So in this case, the residual risk is look how many people who got statins had an event. So the difference between the people who with statins and events and control and events is 2.8%. That's not nothing, but it's not 50%. It's not 22%. So some of the things that you see in the press and in the media, you have to be able to analyze. So the question comes up is, okay, well, how many people do we have to treat to make a difference and prevent one event? That's called number needed to treat. And the number needed to treat is equal to, here's the lousy, rotten part, 1 divided by the absolute risk reduction, or in this case, 1 divided by 2.8%, or 36. So here's how it works. So if you're a group of 36, let's take the first 3 rows here, and I give you all a statin, and we follow you for anywhere from 1 to 5 years, one of you is not going to have an event. 35 of you are going to do about the same as if you didn't have a statin. So if you're that one, congratulations. But the point is that drugs are not going to solve the problem, and that we give drugs to a lot of people hoping that they'll be that one, knowing that they may not be. So we have to be very circumspect when we give someone a drug. We can't give someone a drug and say, this is definitely going to make a difference for you, because we know there's residual risk and we know it may not. So let me show you one more trial. But before I leave this, I would still say there is benefit for statins in certain people, and we have to pick and choose carefully. So here's another trial. This is called the Lyon Diet Heart Study. This is survivors of the first heart attack, followed for about 46 months, although the study ended a little early. And they were looking at people who died, cardiac deaths, or had an MI, myocardial infarction heart attack that wasn't fatal. Smaller study. They had 302 in the treatment group and 303 in the control group. And I'm not telling you what the treatment is, right? Not yet. So of that treatment group, that's only 14 had an adverse outcome. That's 4.6%. In the control group, it was 44. That's 14.5%. That's a big difference compared to the statin trials. Now we're looking at a relative risk reduction of 68%. And that's what the newspaper said. If you do this treatment, you have a 68% lower chance of having cardiac death or a non-fatal MI. That's pretty cool. Your absolute risk reduction is almost 10%. We only need to treat 10 people like this to have an event, to have a positive result, as opposed to 36. So what was the intervention in the Lyon Diet Heart Study? Anybody know? Diet. I gave it away. So darn. I thought I'd surprise you with that one. So it's the people in the treatment group had more bread, root vegetables, green vegetables, fish, poultry, daily fruit. They replaced butter with a canola-based margarine, and they included olive oil. I can't give you amounts. They had less in the treatment group, less red meat, saturated fat, cholesterol, and linoleic acid, which is an omega-6, which is vegetable oil. And that's what made the difference here in this study. This was a diet study in post-heart attack patients, not a drug study. Last one is called the Inner Heart Study. And this study looked at 15,000 people who'd had heart attacks and compared them to 15,000 people who didn't have heart attacks, and looked at these 9 risk factors and did statistical maneuvering to decide which risk factors are most risky for people and which are beneficial for people. So starting off at the top, this elevated ApoB over ApoA, which is code for LDL-HDL ratio or cholesterol-HDL ratio. The higher it is, that means the higher the LDL is, the higher the cholesterol is. ApoB is a protein that lives on LDL, but that's a detail. That's 3 times the risk. So if you're living with a high ratio, and this is something we can measure, you have a 3.25 times risk. Smoking we know about. And smoking, I'm impressed. How many smokers in this room? We got one? Okay. What? Thank you for sharing. That's a brave soul. But we've still got 20% of Americans smoking, so we're not done with that, and it's clearly high risk and over time. Psychosocial factors, 2.67. This was interesting because stress is very hard to quantitate. But what they did is they had five questions. See if I can bring this back. That they asked people. They said, "Do you have stress at home or at work? Do you have financial stress? Have you had a major life event, a move, death of a loved one, something big deal? Are you depressed? Or do you feel lack of control?" The higher the answer to any of those, the more positive was their chance of having a heart attack. It was for me, one of the first really insights into how do we measure stress in people? How do we measure where their risk is? This was very helpful for me. Diabetes, we know. Hypertension, we know. Abdominal obesity, we kind of know. Visceral obesity, which is obesity inside our organs, is probably riskier, but obesity in general is a risk factor. And then we get to the yellows. Regular alcohol, they didn't really give a good definition of that, but the best I can figure is it's 3 or more times a week, and it didn't give an amount. So it's whatever you want it to be. But the take home on it is some alcohol is probably okay, and in this case, it decreased your risk by 10%, 9%. Regular physical activity, which was defined as 4 or more hours per week, didn't define the activity, but it was not just walking around or talking. 14% lower risk, and the winner was fruits daily fruits and vegetables, 30% lower risk. So with this as a baseline of research, let's move on a little bit and start to get into the 4 areas in the heart series that we want to concentrate. The first is exercise, and exercise can be anything you want it to be. We don't prescribe a particular exercise because it's the best, because we know that's not true. Moving is where you start, and then you go from there. The benefits of regular exercise are many, but the key is the underlying word regular. And from people who research with exercise, these are things they pull out of their research. Improved mood, improved self-esteem, reduced stress, improved ability to cope with stress, increased strength, endurance, energy, lower blood pressure, increased HDL, good cholesterol, lower LDL, bad cholesterol, decreased hs-CRP. CRP is a measure of inflammation, so if we want to measure inflammation, we will do a blood test for CRP. Weight control, decreased cancer risk, and improved diabetic control or insulin sensitivity. And I'll tell you just a word about weight control is that we're going to control our weight with exercise and with diet. Exercise is not as effective as diet if you want to lose a few pounds, but it's complementary, particularly for maintaining weight loss. But there are a lot of benefits. And when we talk to people about exercise, we might talk about a prescription. Now, this is pretty detailed, but you need to cover all the different areas. So what type? We would say aerobics, and it doesn't matter whether you're swimming, whether you're walking, whether you're on a treadmill, whether you're on a bicycle. There is no best exercise. It's doing it. It's moving. And weights would be light weights, and the ratio of aerobic to weights should be 2 to 3 to 1. In other words, more aerobics, fewer weights, but both included. How often? 4 to 6 sessions a week. How long? 30 to 60 minutes a session. How intense? Moderate. High intense is not necessary, not important. Now, here's a fun little exercise, because this is a new technology. This is the standing desk. So this is from an advertisement, I'm sure. So here she is working at a regular desk, and then if she elevates the desk, pushes out the chair, moves over to her left, gets on the treadmill, she can walk on the treadmill, we work on the keyboard, talk on the phone, and look at her. Now, how many people can do that? No. That's insane. But at any rate, these things are sold and people do these, but I think the research is what's really interesting that come from these studies. And that's that if you're stepping around, just moving, not standing, not even standing in one place, and definitely not sitting, you're going to burn about 130 extra calories per hour. So if you take 1 hour out of your day and you step rather than sit for 365 days, you're going to consume 47,450 calories. And what that will translate to is about 3 to 8 pounds, up or down, depending on whether you choose to step or sit. And that research, I think, is very practical. You can take that home. You can take it to the bank. So I took it to Boston. So my wife and I are in Boston, and we're in the subway. And we're about to ascend, and I stop, and I go, Pam, would you walk up those stairs? And she goes, why? I said, I want to get a picture. Oh, come on. And, well, at any rate, she humored me. So that's my wife walking up the stairs, because over a couple minutes, nobody walked up those stairs, as you can see from the picture. Pam is the only one walking up the stairs. We give up opportunities to move every day, every hour. And if you think about it, it can make a huge difference without actually formally exercising. This is the effects of walking. This is from the Nurses' Health Study. 88,000 nurses followed for 20 years. They came into the study without any disease at all, and they were followed for development of cardiovascular disease. And they looked at how does walking affect things? And they went from 0 walking time per week to over 3 hours walking time per week. 3 hours is not very much, but again, you have to make the commitment. So the risk of cardiovascular disease events went from 1 down to about 0.6, which means that those who were walking more than 3 hours a week had a 40% lower chance of having a heart event. Just walking. Moving on to the heart-brain connection. Got several slides about this, and this is where we start to talk about stress and the effect of stress on our body. And the part I've been most interested in, and it's been most challenging for me to present, is how does stress end up affecting plaque and causing heart attacks? What is the connection? How does that happen? Well, I'll give you my opinion. The heart and the brain are connected by nerves directly, hardwired. The heart has 100 billion neurons. Think about that one. With a quadrillion connections called synapses. The heart has 40,000 neurons, one study, maybe it's 50, maybe it's 60, but the heart has neurological cells in it connected to the brain through the vagus nerve and other nerves, and signals can go back and forth between the heart and between the brain. But even bigger than this is a system called the autonomic nervous system, which partially involves the heart and the brain, but also involves connections between the brainstem, which is where this nervous system sits, and the lungs, the adrenal gland, the gastrointestinal tract, sweat glands, eyes, everything. This system, the autonomic nervous system, exists below our level of consciousness. We're not aware of it. So if I throw out the term fight or flight response, when we get startled or we get scared or something shakes us up, signals get sent from the brainstem to everywhere in the body. And our heart beats faster, our blood pressure goes up, our bronchioles dilate, our pupils dilate. We get ready to fight or flee without thinking about it. And if that happens over and over and over and over in everyone's day, I'll show you what happens. We have a way that we've come up with to measure the autonomic nervous system. It has a sympathetic side, which is the gas pedal. That's what stimulates us. And the parasympathetic side, which is the brake, which slows us down. The balance between the two determines how much effect are we going to have in our body from these stress responses. We'd like to maximize the parasympathetic side and minimize the sympathetic side. And there's a term called heart rate variability, which I am not going to go into, but we can measure, and we do, with a finger sensor and a program called HeartMath, which gives you a sense of how balanced is your autonomic nervous system. Depending on the results, you can either be sympathetically dominated or parasympathetically dominated, and by practicing stress management reduction techniques, whether it be Tai Chi or meditation, you can rebalance the system. So what does all that mean? How does that get to plaque? And that's where you look at this lady. And it looks, when I saw this picture, I said, wow, she is going to push herself right through that car window. Not a happy face. So do you see what's going on, right? There's something in the seat, and that's her car key. And the button is down, and she is going through a fight or flight stress reaction right now in front of us. Do you know what country she's in? Yep. Man in the front row. See where the steering wheel is? It's on the other side of the car. Come for us. Trivia. So how does stress connect to heart attacks? This is, I've tried to make this slide simple. I can't. But I've figured out a way to go through it simply. So when we're faced with stressful situations, and that's with or without anger, hostility, anxiety, or depression, which have been identified as all emotional states which contribute to plaque, things happen. One which we've talked about is what this lady's going through, and that's the acute fight or flight response. But there's also chronic reactions when we get stressed over and over and over. Can you imagine if you're living in Mosul or you're living somewhere in Syria and you're trying just to get some food or get your kids to school? That's chronic stress, which is a whole different animal. But what's going on is when we're stressed, different chemicals are released in our body, and these chemicals do the things which cause plaque and heart attacks. And I'm not going to go into a lot of detail, but epinephrine or adrenaline comes out of the adrenal gland, increases blood pressure, increases heart rate, increases blood sugar, and can cause the arteries to spasm. Coronary arteries can actually spasm if there's too much adrenaline. There's a syndrome we call the broken heart syndrome or the Takotsubo syndrome, where people get startled, they develop chest pain, they come to the emergency room, their EKG looks like a heart attack, we take them to the cath lab, we shoot pictures of their arteries, the arteries are normal. But the heart muscle's not working. What happened is they got a big bolus, a big amount of adrenaline in their system, caused the arteries to spasm, block off flow to the heart for enough time for the heart muscle to stop working, and then they gradually recover. Cortisol, steroids, increase blood sugar, increase cholesterol, increase triglyceride, increase visceral fat. These next, renin, angiotensin, aldosterone, are all proteins which elevate blood pressure. Plasminogen activator inhibitor and antithrombin 3 and platelets tend to make the blood clot. C-reactive protein, here it comes again, here it is again. That's our inflammatory marker, along with cytokines, inflammation. And we make bad lifestyle choices when we are stressed, when we are anxious, hostile, depressed, whatever, resulting in hypertension, diabetes, obesity, hyperlipidemia, blood clotting, coronary spasm, endothelial damage. That's the connection. It's not just one-to-one, it's many things affecting many things. And the end result is plaque development and plaque rupture. So my belief, and I think Ed and I would be on the same page of this is as important a risk factor as anything else we work with. It's just harder to get a handle on it, but this is why Edna teaches Heart Series participants Tai Chi at every session. We think it's that important. So what do? Well, you identify stressors. You learn to say, what stresses me? When am I going to fight or flight? You have a stress toolbox that you carry around with you so you can pull out guided imagery, relaxed breathing, visualization, Tai Chi, meditation, whatever it is, you can pull out, activate it, and decrease your response to stress. And you can practice daily appreciation and gratitude. I was riding up Mount Lemmon this morning, and I was about to turn around and come back, and somebody else was coming down, and he said, "You got to go up a little further and see the waterfall." And I said, "I'm not sure about that." But I did. So I went up another mile, and sure enough, it's about 10 miles up Mount Lemmon, there is this huge waterfall where I've never seen a waterfall before. It must have been cascading down 100 feet. And so because we talk about appreciation and gratitude, I was able to get off my bike, stop for a minute, and just appreciate the fact that I could be there. And that's all it amounts to. Just those few seconds can make a huge difference, again, in balancing that sympathetic, parasympathetic, autonomic nervous system. And then you have to remember, don't sweat the small stuff. It's all small stuff. We sometimes make too much out of nonsense. Robert Elliott wrote a book called Is It Worth Dying For? A very personal book about something he experienced. But that was his point. That, by the way, is Wilt Chamberlain, basketball player, and Bill Schumacher, jockey, two of the greatest athletes ever. Not quite the same size. I like the picture, so I turned it into something that's irrelevant to the picture, but it doesn't matter. Okay, so we're moving on now. So the history of medicine. Doctor, I am sick. We've had doctors since BC times. So in 2000 BC, we would say, here, eat this root. 100 AD, that root is heathen. Say this prayer. 1850 Industrial Revolution, that prayer is superstitious. Drink this potion. 1940, that potion is snake oil. Swallow this pill. And then we get to my life. That pill is ineffective. Try another pill, which we do all the time. And 2000 AD, that pill is artificial. Here, eat this root. Thank you. And that's what the rest of the talk is going to be about. So I want to take you through. Katie, I might run a little long. We'll see how these guys are doing with that. I'm not doing very well here. This next part is a way that I've tried to study and understand why we can't get our nutritional act together in this country. And I'm going to show you a couple graphs and a couple of my conclusions, because there are no conclusions. But in 1977, a committee chaired by Senator George McGovern in the Senate created our first national nutritional guidelines. And they based it on something called the diet-heart hypothesis. At that time, there was some research which said we could lower cholesterol by drugs and decrease coronary events. We've done the research. This is what happens. Therefore, they decided if we lowered cholesterol by diet, it should do the same, right? That's called a leap of faith. There were never any studies done, never any trials. it was just assumed. If we can lower cholesterol through diet, we're going to decrease events. And faith is believing in something in the absence of proof, which is what happened. So the guidelines came out, and they said, okay, here's what we want you to do. Decrease the cholesterol in your diet to under 300 milligrams. That's a little more than 1 egg yolk. And decrease saturated fat, because there have been many studies which showed that if we feed you saturated fat, we're going to increase your cholesterol. So if we don't feed you saturated fat, it should come down, right? Maybe. And we're going to increase polyunsaturated, monounsaturated fat, but we're going to decrease total fat. So we're going to be kind of replacing saturated fat with polyunsaturated, monounsaturated fat, because that will lower your LDL, which it does. And we want you to increase carbohydrates, but we're not going to tell you how. These are our guidelines. So with those guidelines, our food industry took them and ran and gave us trans fats, which are hydrogenated oils made from polyunsaturated fats, which we're supposed to be eating, but now we've turned natural fats into unnatural poison. Processed food, fast food, processed carbohydrates, and added sugar, high fructose corn syrup, among other things. So that's what came out of it. And then what happened? Well, here's where the guidelines, 1977, and this slide shows calories consumed in green. It shows obesity, which means body mass index above 30, and very obese, body mass index above 40. So between, and it's interesting, I mean, I don't think this was totally cause and effect, but it sure looks that way. When the guidelines came out, we start to see our calorie ingestion go up almost 400 calories a day between the late 1970s and 2010. Our obesity population of BMIs over 30 went from under 15% to over 35%. And our very obese went from about 2% to 5%. So at this point, we're eating more calories, and we're heavier. Probably at this point, 50% of the nation is above a BMI of above 30. And you go, okay, so how did that happen? And that's where it gets interesting. Here's a curve which shows major cardiovascular disease mortality. This is death rates per 100,000 population. So if we go to 1900, and we have to believe the data, about 350 people were dying from cardiovascular disease out of 100,000 in the population. And then the country watched this curve go up and up and up, going, what the heck's going on? This is not good. And it went up and up and up, and then in 1968, it started to drop. And it dropped at 3 to 5% a year, and it dropped and dropped, the 60s, the 70s, the 80s, the 90s, and then we get into the 2010s, it levels off, and now it's flat and maybe starting to rise. So what's going on here? So the nutritional guidelines don't really play a role here, because the mortality rate's already dropping before we changed our nutrition. So what is going on? In 1961, the American Heart Association published a paper with an opinion paper that said dietary fat is related to heart attacks and strokes, and we need to decrease all fat, especially saturated fat. That was in 61. So we started to do that. So we were decreasing all fat. And as we were doing this, we were decreasing red meat, saturated fat, eggs, whole milk, and cholesterol. And we've been doing that for 50 years. We're eating less of these now than we were in 1950. So what does that mean? Does that mean that these curves, this curve came down because we're eating less of this? Well, I don't know. Nobody can prove it to me one way or another. But at the same time, we were increasing cheese, pizza, sugar, sugar-sweetened beverages, trans fats, and poultry. These were going up. So when you look at the curves and you look at people who try to explain them, they say, oh, the reason the mortality dropped is a 50-50 thing. It's 50% technology. We're better at bypasses, we're better at angioplasty, we're better at acute MIs, we're better at ICUs, we're better at diagnosing heart attacks. We are technologically better. And the other 50% is because we're better at prevention. We're using statins. And we're smoking less, and we're treating hypertension, all of which is true. But when you read these papers, nobody talks about diet. It's like, how did that get left out in terms of explaining this decrease in mortality? So my take on it is that this decrease in mortality probably had something to do with this. And then at the end of the curve, I haven't said anything about this yet, but diabetes and obesity began to take off in the 1990s. And that's probably about 20 years after we started to eat more cheese, more sugar, more trans fats, more poultry. So my take on this, and again, this is just my take because I think everybody's entitled to an opinion, and since I'm talking, I get to do it. Decreasing red meat, saturated fat, eggs, whole milk, and cholesterol has probably had a positive effect on mortality, but we can't quantitate it. And increasing cheese, sugar, trans fats, and poultry has probably had a negative effect on diabetes and obesity. And that's all I have to say about that. But what ended up with is Time magazine in 1984 told us that cholesterol was bad. 20 years later, butter is back and fats are okay. And what this did is it left us confused. And what I would tell you about that is that's intentional. That is, I believe, intentional. And we've got a British cardiologist who promotes a high-fat diet. He likes butter in his coffee and advocates for saturated fat as part of a heart-healthy diet. So we've got people, just normal lay people, hearing information from all sides. And I can't blame people for going, you guys don't know what you're talking about. I'm going to McDonald's because you can't give me a reason not to do that. And that's actually somewhat legitimate. I mean, we've got cows telling us to eat more chicken. You've got chicken telling us to eat more beef. And what I like about these is the way they spell more. And maybe it's because you can't fit it all onto that placard, but more is the first syllable in mortality, mortician, moribund. Just an observation. So what's going on here is summarized in a book by David Michaels called Doubt is Their Product. And he goes through climate change, smoking, fracking, and tells how industry has either paid for research or done research which has ended up confusing the world. And the insight here is a cigarette executive observed, doubt is our product, since it's the best means of competing with the body of fact that exists in the minds of the general public. It is also a means of establishing a controversy. And that's what's happening. And that's what's going on. And I feel for people who don't really know what to do because there's so much information, misinformation, and opinion out there. Makes you crazy. So let's move on to what we can do. So when you're trying to think about what you should eat, do you think about the vitamins, minerals, supplements, phytochemicals, cholesterol, saturated fat, monounsaturated proteins? How do you decide? Well, we would tell people you don't. You listen to T. Colin Campbell, who wrote the China study. And he would say that everything in food works together to create health or disease. The more we think that a single chemical characterizes a whole food, the more we stray into idiocy. And I think that's like, you can take that to the bank. So we need to move away from merely chemical ingredients, like saturated fat, and toward food-based guidelines. And this is where some of the thought leaders are taking us. One of which is a journalist named Michael Pollan, who's written some excellent books, one called Omnivore's Dilemma, in which he gave us 7, 8 words. Eat real food, mostly plants, not too much. If you remember nothing else, you're done. And then, in our audience is Dr. Ted Crawford, a plant-based physician, person I admire, who said in a movie that I would recommend to you called What the Health, if you haven't seen it or you can Netflix it, What the Health? What, is that where he said this? Okay, Eating You Alive. Sorry. He's so famous, he's in all kinds of movies. But what he said was that food choices are some of the most important decisions we make on a daily basis. And I think that's really, it's really perceptive, because so much of our eating is mechanical. So much of our eating is just what's there. I'm hungry, I'm going to just take this. I'm not mindful, I'm not thinking about it. And Ted would say, think before you eat. So what we tell people, we try to make it simple. Beans, greens, whole grains, nuts and seeds, and rainbows. That should be the foundation of a heart-healthy diet. Rainbows, colorful foods, which include a lot of phytonutrients, which means they have a lot of antioxidants and vitamins. And just so that we're clear, rainbows don't mean M&Ms. So I'm into my last probably 5 slides, if you guys can bear with me. If we look around the world and try to figure out, okay, what are the models that we have that we can use to tell us what to do? There are models out there. Coronary heart disease mortality varies by at least 5 to 10-fold difference between different population groups. In other words, you can have a population group which has heart disease that's 10% of another. So where are these groups? The Blue Zones is a book by Dan Buettner, commissioned by the National Geographic Society, in which he took a group to areas in the world which had the largest concentration of centenarians, people over the age of 100. Costa Rica, Sardinia, Italy, Okinawa, and a town 60 miles east of LA called Loma Linda, home of the Seventh-day Adventists. And he studied these people, and he put together a Venn diagram on Loma Linda, Sardinia, and Okinawa, Japan. And Venn diagrams, as you know, coalesce in the center. So whatever's in the center of a Venn diagram is common to all 3, but you can't read that. So here, now you can. So this is what it says in the center. These are the things that were common and important to all. Family. Many of the homes were multi-generational. You wouldn't find a nursing home. No smoking, plant-based diets, constant moderate physical activity, social engagement. Each of these societies had ways for people to interact with each other on a daily basis. And interestingly for me, legumes. I threw beans in there. Wow. So those are the common things in societies that are very healthy. And the Adventists have been studying themselves for the last several decades. In Adventist studies, Health Studies 1 and 2, one of the principles that are promoted by Adventists is to be vegetarian. In addition, no caffeine, no alcohol, no smoking, but vegetarian is one. So some of the really brilliant researchers said, we've got a group here, some of which are vegan, some of which are eating meat a couple times a day. Let's see what happens. Let's look at them. So they did. They've got over 100,000 people. And they found that the vegetarians had a lower risk of coronary disease, lower risk of colon, bladder, ovarian cancer, and regardless of your group, if you drank 5 to 6 glasses of water a day, your risk of fatal MI was decreased by 60 to 70%. Fatal MI meaning you died of that MI. Now, they couldn't tell you why, but the researchers said, we're drinking water. And nuts, if you have 5 or more servings a week, a serving of nuts would be about what you can put in your hand without overloading it. The risk of a coronary artery disease event was decreased 50%. And if Mike is out there, this slide is for him. Vegetarians were on average 31 pounds lighter than meat eaters in this study of over 100,000 Seventh-day Adventists. You got it? Okay, good. The Chimane is a native tribe in the Bolivia Amazon. They were in the news several months ago because they are kind of hunter-gatherers, have not been affected by Western food. And some researchers managed to get a truck with a CT scanner into their villages, and they enrolled 700 of them into getting CT scans. A CT scan is an X-ray test. You lay on a gantry, it pulls you into a scanner, you hold your breath for 15 seconds, and boom, the scan's done. And what they were looking for were calcifications in the area of coronary arteries, called the calcium score. You get a number, 0 up to thousands. The higher the number, the higher your risk. The lower the number, the lower your risk. So they took 700 of the Chimane, and those over 40 years of age, 85% were low risk. They said, wow, that's pretty good. What do Americans look like? So they found Americans, matched them in age, sex, height, weight, blood pressure, and found that in the same group of Americans having CT scans, the low-risk group was 14%. The Chimane are active, meaning they don't sit. 90% of their day is active, either foraging or cooking or cleaning or whatever they would be doing. Their diet is 72% carbohydrate, made up of corn, plantains, manioc, squash, 14% fat, 14% protein. Their blood pressures are lower, their blood cholesterols are lower, their heart rates are lower. Just sharing that with you. So, last couple slides. So I said, okay, there aren't really good head-to-head dietary studies between plant-based and animal-based. But what can you learn from studies like the Adventists or the Nurses' Health Study or the EPIC study in Europe, where you look at thousands and thousands of people and you look at what happens to the people who are plant-based and what happens to the people who are meat-based. And so I asked the question to myself, where are plant-based diets more effective than animal-based diets in preventing disease? And here's my answer. In cancer, yes. Heart disease, yes. Stroke, yes. Diabetes, yes. Obesity, yes. Hypertension, arthritis, and Alzheimer's. Plant-based diets seem superior to animal-based diets in all areas. So I said, okay, that's prevention. How about treatment? What if somebody has a problem and you treat it? Then what? Then how does it look? Plant-based more effective than animal-based? In cancer, yes. Heart disease, yes. Stroke, yes. Hypertension, yes. Arthritis, yes. Alzheimer's, maybe. Diabetes and obesity, there are some studies with animal-based diets which are equivalent, and I think that needs to be acknowledged. So at the end of the day, after we've gone through the Heart Series for 11 weeks, we say, okay, what are you going to eat? What's the diet you're going to eat? We look at the standard American diet, which is what we all grew up, well, maybe not all of us, but I grew up on, which is meat, dairy, eggs, processed grains, fast food, fried food, high added sugar, sweets, desserts, high salt, calorie dense, low fiber. That's the standard American diet. We contrast that with whole food plant-based diet, fruits, vegetables, legumes, whole grains, home cooked. I want to emphasize home cooked. We don't do enough home cooking. Nuts and seeds, low added sugar, low added salt, nutrient dense, high fiber. And then we tell people, okay, we don't say pick one. We say make your own diet. You have all the information, make your own diet, because our belief is that it's not fair to tell someone to just do this program because I tell you to. We want to give people information and we want them to create their own program, which will very often include a lot from the right and maybe something from the left, but it's their program. So the best way to achieve good health is to take care of yourself. Your lifestyle is destroying you. You should change your eating habits and stop smoking and drinking. Start an exercise program. Get plenty of rest. Learn how to handle stress. You're right, Doc. Thanks. This happens to me every day. And then as he leaves the office, man, So at the end of the day, and I'm at the end of the day, it's all about balance. It's about trying to balance the many different things in your life and the many different features that can create and cause plaque and cause heart attacks. And there's lots of things that we can do. And then for those of you who've taken the Heart series, you know I like Star Wars and I like Yoda. And so this is a scene from when Luke was trying to become a Jedi Knight, and he was trying to levitate a spaceship.
X-Wing fighter.
Huh?
X-Wing fighter.
Epsilon, thank you, an Epsilon fighter. And he couldn't quite get it to come out of the swamp. And Yoda said, "You must do better." And he said, "I'm trying." And Yoda said, "Do or do not. There is no try."